So with the advent of MRI, CT, everybody said they wrote off the echocardiography and they said that echo will become obsolete. But in fact, echo has come with a bang, because in the cath lab, it is the echo, whether it's a TE, transthoracic or ICE, they're the ones which is important. So among the various types of the ASDs, only the ostium secundum ASD is amenable for device closure, and sometimes this sinus venosus type also. But this is how they look. For this, we have to assess the anatomical rims viewed from the right atrial surface, and the posterior, superior, anterior-superior rims, and the posterior inferior and the anterior-inferior rims are measured. But however, the echo can also assess the morphological variations, whether the deficient aortic rim is there, central defect is there, whether deficient posterior rim is there, which is more often, and then multiple defects, fenestrations, all these things can be measured with the echocardiography. The subcostal view is the best for getting the whole length of the intraatrial septum, because that is very important for to choosing the device. It's not that the size of the ASD and you may take the device, but the 7 millimeter extra on either side, 14 have to be added. So intraatrial septum is measured here. And this is not the right way to measure the ASD. In fact, we have to measure it in the subcostal bicable view. And this is almost like the transesophageal echo. And this is the best view to get the superior rim, inferior rim, as well as the length of the aorta. But however, in the echo, we can measure the rims, but we cannot measure the strength of the rim. The length can be measured, but not the strength. And as a result, here the apical fourth chamber, you have to measure the rims, the whole length of the atrial septum, as well as the VSD. But proper assessment of the rims can also be done with the transesophageal echo, especially in the older. I do the device closure in children with the just transthoracic, but transesophageal is required for the obese and the older people, and here it is very important to measure. And whenever they oversize, they end up with erosion. I have done thousands of cases. Not a single case has ever developed the erosion. This happens when your measurements are not all right. And sometimes I told you the strength of the rim cannot be made out. And as a result, the device can be wobbling at times, and sometimes it can be poking into the aortic valve and then erosion. So echo can demonstrate the placement of the device as well as whether it is oversized or undersized. But today the 4D echo is very excellent. In fact, you can see the various sizes, and when the shape is like this, you are bound to have the residual ASD. And when there is a residual ASD left, in spite of this proper sizing of the ASD, and that can be overcome with the 4D. Now, advantage of the 4D echo is right from the RA side or the LA side, you can measure it simultaneously, and as a result, all the rims can be made out in one go. And as a result, the 4D is very, very handy. And with this 4D echo, we can both avoid the oversizing as well as the undersizing. Apart from that, suppose you have a doubt about whether the rims are properly placed or not, when you do the 4D, you can literally see that intraatrial septum is nicely wedged between the two rims. And apart from that, we were giving 3 months aspirin, 6 months aspirin empirically, but today no more. So this is the autopsy of the animal study, and this is how the endothelium which has grown over the device can be seen, and then you can stop the aspirin once the endothelium has covered the whole of this thing. And what is the beauty? 3 months afterwards, not only it is endothelialized, you can see it both the RA side and the LA side of the device beautifully covered with the endothelium. And especially when there is a fenestration like this, whether the tissue between the two ASDs is small, we can rupture it and make it into one single large ASD and close. Suppose the distance is too much, then we have to sandwich the two devices in one. So apart from that, the contraindications can be made out, and with the TE, this is not suitable. I have put for even 42 millimeter device provided there is a rim, but this doesn't have a rim, so it cannot. So the fenestration, all those things can be made out, and whether to put one device or two devices can be decided. Now coming to the VSD, this is the patient who had 56 years old, came with the cardiogenic shock, and you can see that 2D echo shows just 12 millimeter ventricular septal rupture. Then I thought I'll put 16. And in the past, when they used to fail with the device, they used to think that the tissue is friable and all sorts of excuses we used to give. No more with the 4D echo. Now here you can see that this is from the LV side and this is from the RV side. And what we thought as a 12 millimeter VSD, ventricular septal rupture, and on measurement it was 22/18 from the LV side, and from the RV side you can see that the rugged tissue is there. And this is how we know the device closure, you can do it in a better way. In the past, we were taught that small VSDs no need to close. But today, I do not advise them to leave, because whenever this is from my textbook, Comprehensive Approach, whenever the small VSD is there, because of the Venturi effect, their coronary cusp will be pulled. And as a result, they'll come out with the AR, and then it will be too late. This is a 52 years old person, and look at that. The VSD is very small and they have not closed. And ultimately, what has happened? The severe AR has occurred. So what could have been closed with a simple VSD device? Now the aortic replacement with the patch closure has to be done. So we have to change our thought, because the cusp prolapse is one thing which will lead to significant AR, and then we cannot do the non-surgical closure. So message is, however small it is, you have to assess it properly. Now coming to the Garbude defect, there are two types, the type A and the type B, which goes through the tricuspid valve, and that will look like a tricuspid regurgitation. Many echocardiographers give it as a tricuspid regurgitation, but if they don't see the things properly. So the Garbude is the one between the mitral and the tricuspid valve, in between the small tissue that is there about 3 to 5 millimeter, that is the one. And in the past, the small one was not closed, but I had a patient with vegetation, which I lost 2 years old child. After that, I started closing them with the beautiful ADO2 device, and you get excellent result. This is how the Garbude is from LV to the RA, and that is with the device, and excellent result, and this is published. So this is the 16 years old presented with the repeated respiratory infection, and the surgical closure was done in the past, and now you can see that this is the surgical patch, which is adynamic and that is dynamic. And what you have to see is, during the systole, the VSD, residual VSD is seen. During the diastole, that is the aortic regurgitation. So though this is the residual VSD after the surgical closure, this is not suitable for the device. Whereas this patient, 3 years after surgery, the patient has come with the kyphoscoliosis, and there were multiple VSDs, 4 millimeter, 10 millimeter, 5 millimeters, and then the peer pressure was already 80. But this patient, the surgeon was not ready to touch even with the barge pole. So I closed it with the device, and once the device closure was done, the peer pressure came down, and then the patient, only 4 millimeter small VSD was left, and that's how the patient made a good recovery. And this is the dextrocardia with the VSD closed very beautifully with the Amplatzer duct occluder 2. And this is 15 years old patient, surgical closure, but then the multiple Swiss cheese VSDs are there, the apical VSDs, and here the multiple VSDs were all closed with the ADO2, not 1, 2, 3 VSDs, and that's how we know pre and the post you can make a good result. And this patient had a large VSD with the PA pressure was very high. The PA pressure was almost 92/60, and then I closed it with the 24 millimeter device, and the PA pressure came down. I had made a fenestration into the device, and now she is 22 years, working, graduate, and she is ready to get married. And this is how the the echo can help you to make the precise diagnosis. This is a large VSD. And I thought I have done very simple, and I have done the closure. And what happened was the echo machine was not there, and with overconfidence I left. But then the BP started dropping, patient developed bradycardia because the echo machine was not there and it had gone for the PTMC for the another lab. And then you can see that the device is, the retention skirt is trapped in the tricuspid valve, the chordae, and then the patient had a severe tricuspid stenosis as well as the regurgitation. And what I did was, inflated balloon, I pushed it like a crane, lifting and pushing it back, and you see that the device fell back. So everybody started clapping, thinking that now I can catch hold of it and pull it. But then you see that the device is smarter than us. It went and sat in the place, and so beautifully it is closed. And thanks to the echocardiography, because the OR was not ready, and if I had not done this, I would have lost the patient on the table. So till now, I have never lost one, thanks to the echocardiography, which is always handy. So friends, echo is used appropriately. Whatever the attractive device closure, it will not end up with the crash and the nightmare, thanks to the echocardiography, peri-procedure as well as post-procedure. And thank you very much for your kind and patient hearing. Thank you.